Welcome, everybody. This is the Rotary E-Club of Silicon Valley, and every week we bring you the stories of people who are making their communities better. Those communities might be local, they might be global, they might be digital, but the idea is that you are taking a certain amount of joy and meaning through helping others. Our programs are designed to inspire people through stories of great things happening in a way that might make you say, we need to make that happen in our community. And the life experience and efforts of our guests today are very much in that space of getting a chance to hear something inspiring for which there may be a great need where you are. Our speaker, Dr. Donna Adams-Pickett, is the CEO and owner of the Augusta Women's Health and Wellness Center. And she has this wonderful bio. Those of you watching it on YouTube, pause and then go down and take a look at the full thing. If you're on our SiliconValleyRotary.com page, you can do the pause and then scroll up. If you are listening to this as a podcast, feel free to look at the description notes to get the full story as well. But we are excited to have her with us. And Donna, if I may call you that.
Yes, please.
Welcome. It is so cool to have you speaking to the Rotary E-Club of Silicon Valley. Please share your story.
Well, it is a pleasure to be here, and thank you for this opportunity to tell my story. I like to call myself what I call a women's healthcare warrior, inspired by a story that my father told me at about the same time in his life. It was about the time that his life changed. He told me this story. I was about in the sixth grade, so I was a little under 12 years old, and he told me that when he was 12, his life changed because his mother went off to have his baby sister, but she never came back. This was in 1943 on a little tobacco farm in Greenville, North Carolina. And what he knew about when women had babies was that every time his mother would go away, they would worry that she may never come back because most of his friends in his little tobacco farm, they knew that having a baby was a scary thing. So every time she came back, he was so excited. But this one last time, she never came back. And that changed his life. And in turn, it changed my life because I never wanted another dad to have to tell his daughter that story again. And it shaped what I do as a living now. I am an OBGYN and have been one for 23 years. But for the last 2 years, I've had to stop delivering babies, but that has not changed my concern and my passion for taking care of women because I do believe that I still have a role in this area. And one thing I know now that even though that was 1943 and it is now 2025, that when many women get that little purple stick that says they're pregnant, that many of them have the same fears that my dad did, which is, am I going to die? Is my loved one going to die? And I always like to take a moment when I'm telling this story to take a breath. Because sometimes when we have discussions about health equity and health education, they could be a bit triggering to the point of trauma to the point of paralysis. But I don't want those of you who are chatting with me this afternoon to be paralyzed. I want you to be energized. I want you to be galvanized. I want you to be motivated. But before I motivate you, I feel like it's necessary that I educate you. Because, in the words of that great 21st century philosopher that's off quoted, Beyonce, uh, America, America's got a problem. Um, as far back as 2020, 2019, actually, approximately 20 out of every 100,000 women died during pregnancy, childbirth, and the postpartum period. That was roughly about 760 women. By 2020, that number went up to 23 out of 100,000 women for about 864 women. By 2021, that number went up even further to 33 out of 100,000 women for about 1,205 women who have families with these huge gaping holes in them were there. And during this time, we had launch of 5G, OpenAI, ChatGPT, all of this technology. And you add to those other numbers that I mentioned that over 50,000 women almost die each year due to pregnancy complications. So if you look in the rearview mirror, you're looking at nearly 3,000 women who were dead and over 150,000 women who almost died from either a physical or psychological event. And this is the same time we had billionaires who were taking private jets to the moon or private vehicles to the moon. And that's relevant to this discussion because the CDC actually did a retrospective analysis and found that 80%, actually 82% of those deaths were actually preventable. So the reason why I mentioned those technological advances is because I feel that all of that technology still managed to elude and not trickle down to taking care of the pregnant women in this country. And while those are sobering numbers, for me, what's really sobering as a Black woman, Black physician, and mother to a Black daughter, that Black women are 3 times more likely to be in those numbers, particularly those numbers of those who die, and definitely in those numbers who almost die. And that is regardless of socioeconomic status, regardless of education status, regardless of geographic location. Um, we tend to die more. And often we're asked why. Why is that? So I'm going to throw a lot of stuff at you in today's chat, but there is one thing I really, really hope you take home with you today. And that is that there is no biological or genetic predisposition among Black women that make us more likely to die during pregnancy, childbirth, and the postpartum period. Remember, 82% of those deaths were preventable. So it is not the biology of the pregnancy or biology of the woman herself that has caused this situation. It is the system surrounding that demographic that has made that happen. So one of the things that came up in that study is that the CDC also found that 1 out of 5 women felt that they were mistreated during their pregnancy. And that leads us to the topic of bias. Bias, whether implicit or explicit, can impact pregnancy care tremendously. There's this little thing about the concept of bias. People often conflate bias with racism and sexism. And I reject that notion. I really do. I feel that bias is really based in ignorance, that you just don't know what you don't know. So if you really haven't been exposed to certain genders and certain cultures, there are nuances that you're just unfamiliar with. So those nuances, whether they're physical or emotional, may impact care. So if just as an example, if someone has a patient who is overly dramatic or over expanding their symptoms, that may just be in their culture. They're very, very expressive. Or symptoms may be ignored because we're told, well, they didn't really seem like they were in a lot of pain. They didn't really act as if they were hurting. With some cultures, stoicism is appreciated. And typically in that culture, it is not acceptable to be very expressive. The patient in turn, actually sees that their provider is not really going to take them seriously. So then they aren't as expressive with their care provider, and there's a wall there. And that wall prevents shared decision making, shared medical care. And the result is the patient suffers. And the result is we have the numbers that we have in the United States now. So there's this quote by Dr. Martin Luther King that I love to quote often, which is, of all the forms of inequality, injustice in healthcare is the most shocking and inhumane. And that takes for me to access. And I want to talk a little bit about access. The March of Dimes states that 1/3 of all U.S. counties are considered maternal health care deserts. So that's about 2.2 million women are living in counties that do not have an obstetrical unit, an OBGYN, a midwife, a birthing center, even a clinic for prenatal care. So here for me in Georgia, that's 81 of our counties. But to be more exact, more precise, between me to the east of me, it's about 84 miles to the next city that has obstetrical service. To the west of me is about 96 miles. So nearly 100 miles between me and the next county that has obstetrical services. Why is this happening? Why is this happening across the country? There's a massive closure of maternity ward units across our country due to two things: poor reimbursement for women's health services, whether it is commercial insured or Medicaid, and increasing litigation costs. So for the hospital systems, they're getting so little in, but putting so much out. So for them, it's very expendable to remove obstetrical care services from their care lines. The second issue is that you have fewer and fewer medical students who are choosing obstetrics as their subspecialty. They fear the lawsuits and they definitely don't want the lifestyle. A lifestyle that comes from being there's only a few of us to take care of so many people. So they're just like, we're not interested in that. But there's another component of access that is contributing to the cost of care, decreasing available number of obstetricians that we must also discuss. And for me, this is when I say I have to talk about the quiet part out loud. We cannot possibly have a conversation about maternal mortality in this country without having a conversation about reproductive rights. You just can't. It is no coincidence that the states that have the highest maternal mortality rate also have the strictest reproductive health laws. And as an obstetrician for over 23 years, I feel like I need to state the obvious. Not all pregnancies are inherently healthy pregnancies. And maybe that isn't so obvious. So I'm going to give you a little biology lesson here. And that biology lesson is that all women are born with every egg that we're ever going to have. It's something like 1.2 million eggs. And every man makes about 20 million sperm every 72 hours. Now, think about it. There is no way that it is statistically possible that all of the millions of eggs and all of the millions of sperm are perfect. There are going to be some that are flawed in some way. And sometimes you have a flawed egg coming together with an imperfect sperm or either or, and it creates an imperfect pregnancy. It creates an imperfect placenta that places the mother's life in danger. And additionally, remember I mentioned like 50,000 women almost die every year. And of that 50,000, we beg them, please don't get pregnant again. But there is no contraception that is 100% perfect. I personally have delivered my share of post-tubal ligation and post-vasectomy babies, quite a few over my career. So you will have women who did everything that they thought they could do, and they find themselves facing this life-threatening condition. And for them, pregnancy is a life-threatening condition. And then you have malpractice insurance carriers who are unwilling to insure those of us who are willing to take care of them, particularly if we're living in a state with very strict reproductive health laws. So I personally, as part of my story, decided to embrace Fannie Lou Hamer. I'm sick and tired of being sick and tired. So I have decided that what I'm going to do, I work. I do what is necessary. And I hope that anyone listening to me today, maybe you'll be moved and you're willing to do the necessary work with me. And so, because 3 years of statistics have shown us that we cannot depend on change to spontaneously occur, that our country is demonstrating by its inaction that women of reproductive age are not a priority unless we're putting guardrails over their reproductive choices. What we can't do is do everything we can to keep women pregnant and then not do anything to keep them safe when they're pregnant. So what I'm doing my part. I hold educational forums in my community. I do it remotely to communities just like this, where I hold classes to freely discuss reproductive and women's health. I hold classes for birthing people and their support persons to network them and to provide them with resources so that they know not only how to be healthy during their pregnancy, but how to advocate for themselves during their care. And then in all my social organizations, I advocate for legislation that provides funding to entities who are willing to take a chance and bring reproductive health services back to those underserved counties. I advocate for legislation that supports tort reform so that more obstetricians are able to stay in practice and we can recruit more to come practice with us. I am addressing the decision makers in the insurance industries to encourage them to increase reimbursement for women's healthcare services. I support body autonomy for reproducing individuals to make their own healthcare decisions when it comes to their GYN health. I strongly, strongly support diversity, equity, and inclusion programs so that we can encourage the presence and perspective of people from different genders and different backgrounds to reduce bias so that we can learn how to take care of everyone. We can meet every patient where they are. So this is what I'm willing to do, and this is what I'm doing. And I hope that you will find someone in your community willing to do the same.
Wow, Donna, that is a wonderful. Thank you very much for the presentation. And I've gotten a nice long list of questions for us. And excited to jump into this to you. I mean, like this starts with the story of you and your dad, right? And looking at that moment and thinking about how things get started anywhere, somebody working to make a difference in their community. Not only were you moved by the story that your dad told you, but you had a sense that you could do something.
Yeah.
Tell me a little bit about how you decided that's something I can do, as opposed to that's terrible, but
Well, what's really interesting also about that story was that because my dad was the oldest, he had to stop his education then. So he stopped going to school at 12 years old. He had a sixth grade education. So he could help his dad take care of the younger kids. But he truly, truly, because of that experience, recognized the importance of education. And I'm the youngest of 10. 8 of us went to college because my dad felt that I did not have this opportunity, but there's so much that you can do with an education. And I feel like you guys are the smartest things that I've ever created. The best, he poured into us that we were the best things that he ever made. And with that, I just felt that I could do anything. And I loved my father so much. It was the first time I ever saw him cry. And I never wanted to see another dad have that moment with his daughter
mm,
again.
so wow. So this is your numbers are particularly fascinating for me. I mean, I've seen morbidity rates, and birth, these numbers get thrown all over the world, but especially powerful for me was that 50,000 women almost die
Almost
every year, and that's just the United States.
That's just the United States. All of the numbers are totally the United States.
So we're talking about for every woman that dies, absolute tragedy that is. We're talking about another thousand or more, right? That if they didn't get exactly the care they might get,
Mhm.
they too would be part of that morbidity rate.
Absolutely. Absolutely.
So So clearly, getting people from any perspective on any particular issue to stop and go, that's important, comes down to stories and good data.
Yeah.
And I'm wondering if there is a systemic way of tracking the the figure of how you get to the figure of almost die, right? Because I would assume that there are certain conditions that require certain interventions that allow it to be kind of a this person had this intervention not been there might have died or
Right.
might surely have died, right? And so that kind of thing of how do we help people better understand the numbers? Can you describe some of those conditions, like because I assume it's quite a range.
Yeah, it is. It is. But some of the hospital systems are recognizing that. So there are reports on how many hospital postpartum hemorrhages there are, how many readmissions to the hospital that they are immediately within the first seven, then days of delivery, within the first 14 days of delivery, because typically if there's a readmission, there's a complication, whether it's due to infection, hemorrhage, cardiovascular compromise, how many patients have to be moved to the ICU to a higher level of care, how many patients have to go back to the operating room because of a post-operative, post-delivery complication. So they're tracking those things. And at one point, there was a discussion about giving hospital scorecards based on the number of readmissions, the number of moving to a higher care, the number of postpartum hemorrhages. And the scorecard would be tied to federal funding. So it was an impetus for the hospital system to improve these matters, to make sure that they had necessary training for their staffs to recognize those sentinel events that would identify these complications were getting ready to occur. Much of that is not necessarily available to us now,
The
federal funding.
no, right. And and if we're looking at something like good data
Mhm.
and knowing how many women, what percentage of women come back as a result of complications, does that also run the risk of further incentivizing the hospitals to deny care to those who might be of higher risk, or was that built into the numbers of population related uh, statistics so that too could be spotted if it is happening?
I think when the incentives originally were, if you decrease these numbers, then particularly with the training of um, the OB staff, but not just the training of the OB staff, with the nurses and ancillary care, your local emergency rooms. There's a number of these patients would call the emergency department or go to a remote emergency department. And because these hospitals, the ER, did not have obstetrical training, they're sending patients back out the door who then go home and die, or they come back and they have significant complications. So what some hospitals have started to do was to create OB EDs, an ER specifically for patients who were about to deliver or just recently delivered. So you had more coordinated care that was honed in to the nuances of a pregnant patient or recently delivered patient. And that really had been the move for many of the maternity wards across the country. But that takes money and effort. And so if you have a hospital system that's kind of struggling in the first place, then they'll just close their obstetrical unit. And now the patient is having to drive further to find that hospital system that actually has those services.
Thinking about the services that become available and the diversity of the people who are there to staff these programs,
Mhm.
because you talked about you called it the kind of lifestyle thinking,
Mhm.
about obstetricians, and the idea that, oh, this person, I don't know that I trust that this person is in as much pain as she says, or this person doesn't seem to be in so much pain. I thought you painted that picture very, very vividly. If there are more teams following better data so that it is recognized that the nursing team is able to provide input, that is tracked in a way that is meaningful, that might shake loose tests that need to be administered at a time. I mean, I'm sensitive to the idea that pain is hard to measure,
Mhm.
but it would seem that there's some pretty basic things hospital teams could do to make sure that they're checking with each other, that they're really tapping the talents of everybody on the team to figure out whether someone who's come in might have an issue that the lead person has not spotted.
Right, right. And one thing in medicine, we have to do continuing medical education, at least the physicians do. And I feel that part of continuing medical education, we need to have ingrained some degree of cultural sensitivity. I can't tell you how many times I've walked in a room and the patient looks like me, and there's a audible sense of relief. It's like, okay, you'll understand, even though we're both speaking English, but again, culturally, they understand, they feel safe with me. They feel safer with me. And the same, I find this with Hispanic patients that, you know, they're trying to they're trying to translate, and they may speak English as a second language well for everything else, but when it comes to medical descriptions, this is something that eludes them. And as soon as someone walks in and they speak the language fluently, okay, man, okay, I can really speak freely about what's happening to me medically. I mean, medical jargon is a whole language itself, you know? It really is. So, um, it would be helpful.
It's striking that the attention to cultural changes and cultural differences is absolutely obvious to the business people who might be seeking to open up a market in a different place. You can't send somebody down there who's not going to talk a language that the people don't have an interest in hearing, whether that's the language itself or just the nature of the communication. I mean, it's completely obvious to businesses that that's important. I remember the Chevrolet initially trying to sell the Nova in one of the Spanish-speaking countries of Latin America, and Nova in Spanish means it doesn't go, right? And
Nova. It's got Nova. Got it. See?
it's one of those like, oh, come on, right? And so it's so obvious in a business setting, and in a healthcare setting where what decisions get made matter so much that this wouldn't be completely obvious to people is a shame. And
I
that's bringing
mean,
it
and
lightly.
again, it's more than just, races and cultures. But one culture is that, I'm here in a military town. I
Mhm.
find that military patients typically express themselves very differently. And again, I may walk in the room and, someone may say, well, she's not very expressive. She can't possibly be hurting as much. But I know that patient. That patient is a major, they're very, normally very flat effect. And if I see one tear coming down their eye, then I know for her, this is huge and something's really going on here. We need to act quickly. So I think, diversity in experiences, diversity in different, your southerner is going to react a little differently during labor than your person from your New Englander, definitely different from your New Yorker.
So, and in thinking about geographic difference, yeah, I'm I think about what it means. Like if you've got three times as many black women dying under the same circumstances as white women, then clearly there's a problem, right? And bias along the lines you've described is has got to be part of it. Is it also part of the research you've done that the income level, resources, food desert issues related to general health also begin to become part of the scene, such that you find women in rural areas are having much greater morbidity rates, and then also just this figure about almost dying, which needs a good name. Maybe it has
Yeah, yeah, yeah. Yeah, and rural women are 1.5 times more likely to die
one.
during regardless of race. Um, with Black women, we have found, I mean, those studies have actually found that even Black women with terminal degrees still have worse outcomes than other ethnicities who have not passed their high school level. So, some of the more stories that receive lots of attention have been of like a Black pediatrician. She was actually a doctor, and she died during her pregnancy because it was thought, well, you're a pediatrician, you couldn't possibly know all the nuances of obstetrics. Don't be the doctor now. And, she was told, don't be the, when she went in complaining of a significant headache. It was, don't be, you need to be the patient and not be the doctor. So, and again, one of those preventable losses in that 82% that didn't have to happen.
Mm. Two more questions for you,
Hmm.
maybe two more topics, right, rather than two more questions. One is that the dearth of obstetricians, OBGYNs in rural areas. You described in your presentation, in your talk, about how there is this issue of people choose not to go in part because there's so few people in there, because if you do that, you're going to have so much on your shoulders
Hmm.
because there's so few people in there.
Hmm.
Well, that is a horrible spiral for making a terrible situation much worse, right?
Right,
Have,
right.
have you have you encountered any creative approaches to addressing that?
No, I mean, those times like that, I really do feel helpless about it, because before I stopped delivering babies, and I'm a solo provider, was delivering 30 babies a month, 30 plus as one person. Um, because again, roughly 100 miles each way, there are no obstetricians. And just again, statistically, if I am delivering 30 plus babies a month, particularly from women who likely did not have any type of medical care at all prior to getting pregnant, so they are sicker. So, it's not like the baby story show that used to come on TLC where, I'm going to take care of them, and 40 weeks later, after three commercial breaks, we have a baby and a happy story. These are very, very sick women. So we're, we are really, really enmeshed in their care. And then that increases our liability significantly. The numbers crunchers, the underwriters from the back look in and say, hey, she's seeing a lot of people. They're really, really sick. She's in a red state. There is a very good, not possibility, but probability that she is going to enter into some type of litigation very soon.
Hmm.
And then it becomes we can't afford to continue to do the work.
Yeah, it's heartbreaking.
It is heartbreaking. It truly is heartbreaking.
So let's finish with this topic. Uh, we recorded a program quite recently with a woman in Guatemala who has been working with a team to develop with indigenous Mayan Guatemalans, an app for midwives to help them better understand when a birth might result in a complication that should speed the process, again using the app, of contacting people so that a care can come to the woman in this village, and this kind of thing. Is it that an approach to, and I'm not sure exactly what even the proper word is, midwifery,
Midwifery. Hmm.
midwifery,
Hmm.
is something that could lessen the burden on the system? The system needs to improve, but is
Hmm.
it the kind of thing that could lessen the burden on the system to some degree if, let's say, 80 to 90% of births can be handled naturally at home, and the system can focus on those who are having issues that are identified by midwives? Is that a possibility?
Absolutely. So you're the second person today that's asked me this. I'm thinking maybe something must be getting ready to happen. A legislator asked me this earlier today. Absolutely. The wrinkle with that is that obstetrics, out of all of the types of medicine, is probably the most unpredictable. So the most normal pregnancy, normal labor, just moving along beautifully, can change without any indication that, okay, now this is an emergency. We have to take it to the operating room. We have to, and so midwives are available, but when that situation changes and you need immediate emergent intervention, there's no place nearby and no for the midwife to take that patient to, and there's no one to step in to help with that.
There are clearly a lot of needs that need to be addressed here for sure.
Yes.
And Donna, your story and your attention to detail, and your passionate advocacy for those who are seeking to make a difference in this space is really appreciated. Thank you.
Thank you. Thank you so much for having me. I really appreciate this opportunity. Really.
Absolutely. I'm going to hand it back to you in just a minute, but for all of you who've joined us for this recording, whether you are watching it as a video or you are listening to it as a podcast, thank you for spending your time. It is important to us that we are able to connect with people who can tell the stories that allow us all to make the world a better place. And we hope that you are regularly coming back and catching the inspiration that comes from these kinds of messages. As we always like to do, we hand it back to our speaker for the final word. So, Donna, what would you like people to have clearly in mind as they finish watching the video or finish listening to the podcast?
That the strength of our country relies in the health of the women in our lives.
Amen. Everyone, thank you. We will see you next week.